Hello everyone, welcome to Alacrity Explains Anatomy. Today we are going to be looking at osteology of the sternum. So by the end of this video, you should be able to identify the three main parts of the sternum, which is the manubrium, the sternal body, and the xiphoid process. You should be able to palpate and describe the bony landmarks, including the suprasternal notch, the clavicular notches, sternal angle of Louis, and xiphoid joint. You should be able to explain the articulations of the sternum with the clavicle and the costal cartilages. You should be able to locate the sternal angle and demonstrate its clinical importance as a surface marking for rib counting and mediastinal structures. You should be able to describe the ossification centers of the sternum and their clinical relevance, as well as identify common anatomical variations and clinical conditions, sternal foramen pectus deformities. Now, the sternum is a flat dagger-shaped bone located in the anterior midline of the thoracic wall. This is the sternum. See, it's dagger-shaped. A dagger-shaped bone located in the anterior midline of the thoracic wall. It serves as an anterior anchor for the ribs. Helps for attachment points for the clavicle and some thoracic muscles like pectoralis major, sternocleidomastoid, rectus abdominis muscle. It serves as a protective shield for mediastinal viscera like the heart and the great vessels. In general location, it lies at T1 to T10 vertebral levels, as the thoracic vertebral levels, though it is directly anterior to T5 to T8. So this is an image of the sternum. See the manubrium, you see the body, and we see the xiphoid process. So we'll start with the part of the sternum, which will look at the manubrium. So it is roughly trapezoidal, it is the thickest and the widest part superiorly. It has important landmarks like the suprasternal notch, which is also called the jugular notch. It's a U-shaped depression at the superior border at the level of T2 to T3. If you look at this image, you see the depression here, the jugular notch, which is U-shaped. It also has clavicular notches, which are paired over facets on the superlateral edges for articulation to the medial ends of the clavicle to form the sternoclavicular joint. These are the clavicular notches for articulation with the clavicle. We also have the first costal notch on the manubrium, which is on the lateral border for the first costal cartilage of the first rib, synovial and a synchondrosis joint. And we also have a second costal notch on the inferiolateral border, and it participates in the joint of the second costal cartilage, though it is half on the manubrium and half on the sternal body. If you look at this image, you see that this is for the second, this is for the first. The one for the first is on the manubrium. The one for the second is half from the manubrium and half from the body. Now let's look at the sternal body. The sternal body, if you look at its shape, it is longer, narrower, and thinner than the manubrium. Multiple transverse ridges are located on its anterior surface, which mark the lines of fusion of the four sternibrae, that are the embryonic segments of the sternal body. The embryonic segment of the sternal body is all referred to as the sternibrae. So the anterior surface mark lines, they represent the fusion lines of these sternibrae. What are the important landmarks? We see the costal notches, which are facets on the lateral border of the facets on the lateral border of the body of the sternum, which are for attachment to the costal cartilage of the second to the seventh rib. We have the second notch, which we already know that it is being shared with that of the manubrium, so half from the manubrium, half from the body. We have the third to the sixth notches, which are single complete notches on the body of the sternum. We have the seventh notch, which is at the inferior angle and is partially with the xiphoid process. Half on the body, half on the xiphoid process. We have the sternal angle of Louis. Now the sternal angle of Louis is a slight forward angle ridge at the manubrium-sternal joint, at the joint between the manubrium and the body of the sternum. Call this joint the manubrium-sternal joint. The junction of the manubrium and the body. It is a clinically important point, landmark on the body of the sternum. This is our sternal angle, also called the sternal angle of Louis. Now moving forward, we see in this image, you can see the demifacets, half on manubrium, half on the body. You can see the other articular facets. This is the manubrium, this is the body, and this is the xiphoid process. So moving forward, let's talk about the xiphoid process. The xiphoid process is small, thin, and cartilaginous in youth. It ossifies completely by the age of 40. And if you're watching this video and you're not yet 40 years old, it means that your xiphoid process is yet to completely ossify. It has a variable shape. It is pointed, bifid, curved, and perforated. For important landmarks, we have the xiphoid joint, which is the joint between the sternum and the xiphoid process. The joint between the sternum and the xiphoid process, we call that the xiphoid joint. We also have attachment sites, which is for the diaphragm, the central tendon of the diaphragm specifically. Now, this is majorly located on the inner aspect of the xiphoid process. You see attachment site for the diaphragm, that's its central tendon, as well as the rectus abdominis muscle and the linea alba. We're going to talk about these structures in our subsequent videos, but make sure you have an atlas to see these structures. But on the inner aspect of the xiphoid process, the structures are attached to the xiphoid process. Now, what is the clinical warning? There's an important clinical warning. The xiphoid process is fragile. So during a cardiopulmonary resuscitation, that's CPR, when performing CPR, it is improper hand placement can fracture the xiphoid process. So this knowledge is very, very important. Because the xiphoid process is fragile during CPR, proper hand placement is very, very important, because an improper hand placement can fracture the xiphoid process, resulting to a potentially lacerating liver. So this is the xiphoid process, as you can see in this image. Now moving forward, let's talk about the joints of the sternum. For the joints of the sternum, we have the sternoclavicular joint, which is the joint between the medial ends of the clavicle and the mandible. And is the only bony joint between the upper limb and the trunk. The sternoclavicular joint is the only bony joint between the upper limb, everything about the upper limb, and the trunk. We have the mandibulosternal joint, which is the joint between the mandible and the sternum. And this is the joint we refer to as the sternal angle of Lewis. It is slightly movable. Don't forget, it is slightly movable. It's a secondary cartilaginous joint. It's a what? Secondary cartilaginous joint. Now, for the xiphisternal joint, it's between the sternal body and the xiphoid process. It is a synchondrosis made of hyaline cartilage, and it is normally immobile. We have the sternocostal joints, which is the joint between the sternocostal notches, the notches that we find on the lateral aspect of the sternum, as well as the costal cartilages of the first to the seventh rib. The first is a synchondrosis, while the second to the seventh is a synovial planar joint. The first is a synchondrosis, while the second to the seventh is a synovial planar joint. So as you can see, these are the joints. We have the sternoclavicular joint, which is between the sternum and the mandible. We have the anterior interclavicular ligament, the ligament that is helping to support the sternoclavicular joint. We have the sternocostal joint, which is between the sternum and the costal cartilages of the ribs. We have the sternal angle of Lewis, which is also called the sternal angle or the mandibulosternal joint. We have the xiphisternal joint, and we have the costoclavicular joint, the ligament, sorry. Now let's talk about the sternal angle of Lewis. We said it is clinically important. Now, like we already seen in so many images, it is palpable. The palpable ridge on the anterior aspect of the chest, 5 centimeters below the suprasternal notch. 5 centimeters below the suprasternal notch. Now, the vertebral level, it matches with T4 to T5 intercostal intervertebral disc. It matches T4 to T5 intervertebral disc. Now, why is this knowledge of the sternal angle of Lewis important? It helps in rib counting. It marks the attachment side of the second rib, so it is used to count ribs or intercostal spaces for auscultation, as well as insertion of chest tubes and ECG lead placements. Very, very important. Secondly, the aortic arch. The aortic arch is located around this region. It begins and ends at this point. So the beginning and the end of the aortic arch lies at this level. The tracheal bifurcation, that's another important point. The trachea divides into a right and the left main bronchi at the sternal angle of Lewis. So at the pulmonary trunk, we divide into the right and left pulmonary arteries at this point, and it horizontally separates the superior from the inferior mediastinum. The sternal angle of Lewis is a point that marks an imaginary line. It represents an imaginary line that separates the superior and inferior mediastinum. We have the zygous vein, which arches into the superior vena cava at this side. The zygous vein arches into the superior vena cava at this side. There are other events that occur at the sternal angle of Lewis. Do well to look them up. Now let's talk about the ossification and age changes. Now at birth, At birth, the sternum is completely made up of cartilage, or mostly made up of cartilage, allowing for compression during birth as the child passes through the birth canal. The mandible has about 1 to 2 ossification centers, and the body is in segments, which we call what? Sternebrae. Call them sternebrae. Now, from childhood to 25 years, the sternebrae fuse from inferior to superior. From what? Inferior to superior. The fusion of the sternebrae is from inferior to superior. Don't forget, the body fuses with the mandible and the xiphoid later on. The xiphoid process ossifies, like we said earlier, at age 40 years. So, at old age, the sternum may become more brittle and susceptible to fractures. Clinical correlates. Why is this knowledge important? Talk about a sternal foramen. Sternal foramen. Let me show you an image. This is sternal foramen. We have a hole in the sternum. It's called the sternal foramen. You can see it in xiphoid foramen. So the sternal foramen is an incomplete fusion of the sternebrae. Whenever the sternebrae, which are supposed to fuse from inferior to superior, fuse incompletely, a hole is seen in the body of the sternum. And this can be mistaken sometimes for a gunshot wound on X-ray. It is potential risk during acupuncture or bone biopsy, which may puncture the heart or the mediastinum. Is a potential risk, because if the knowledge that there's a foramen here is not known, this might cause the puncture of the heart during a biopsy, or the biopsy needle getting into the mediastinum. We also have pectus excavatum, which is referred to as funnel chest. Now look at how a funnel is. There's a depression. When you talk about funnel, there's a depression. So this is pectus excavatum. Excavate, a depression. When you see a depression going in, pectus excavatum. When you see it coming out, pectus carinatum. So the pectus excavatum is a depressed sternum. Most common chest wall deformity. It is the most common chest wall deformity. It may cause cardiopulmonary restriction in severe cases. We have pectus carinatum, which is pigeon chest. It is a protruding sternum, mostly cosmetic issues, but can be associated with connective tissue disorders like Marfan's syndrome. You can see it pushing out, pectus carinatum, pushing in, pectus excavatum. Good. So we have more clinical correlates to look at. We have sternal cleft. Sternal cleft is a rare congenital failure of sternal fusion, when there is failed fusion of the sternum. You see a cleft is formed in the sternum. So these clefts are of types. We have the superior sternal cleft, we have the subtotal sternal cleft, we have the total sternal cleft, and we have the inferior sternal cleft. So it leaves the mediastinum exposed and requires surgical repair. We have sternal fractures, which are often blunt trauma, for example, steering wheel injury, and high risk concomitant cardiac contusion, myocardial injury, or thoracic vertebral fractures. When there is a fracture, as you can see here, fracture of the sternum is very, very dangerous. We now have a sternal biopsy. Now, for sternal biopsy, to biopsy the mandible, the mandible is the site for marrow aspiration, alternate to the iliac crest. The iliac crest is the most preferred site, while the mandible is also a site for marrow aspiration as an alternative to the iliac crest. It must avoid overpenetration. You must avoid overpenetration due to posterior structures like the great vessels and the heart. The arch or the aorta are in relation to the mandible posteriorly. So during this procedure, sternal bone marrow biopsy, you need to be very careful not to overpenetrate the bone. So That's what you have. So review questions. While performing a physical exam, you palpate a horizontal ridge 5 centimeters below the sternal notch. Which rib do you identify just lateral to this ridge? Drop your answer in the comment section. 2. A 70-year-old patient has a completely ossified fused xiphoid process. Is this normal? What do you think? Do you think this is normal? I want to see your answer in the comment section. A patient has a congenital hole in the lower sternal body. What is the name of this variation and why is it important clinically? Please drop your answers in the comment section. Thank you for watching. Like, comment, and share this video. And don't forget to subscribe to Alapiti Explains Anatomy. Thank you.